Depressing Misinformation. 6 Myths About Depression Debunked. Hello, my name is Donald Best, and welcome to the Am I Crazy video series. The goal of this series is to remove the barriers so many of us have to taking care of our own mental health. Before I do a more basic presentation about depression, I'd like to detox from some common misconceptions about it. And at the end of this video, you'll be able to understand depression better and therefore respond in a more helpful way when this very common problem affects you personally. Number 1. Depression is not a mental illness, but a chemical imbalance in the brain. This may have started as an oversimplification as doctors tried to explain to their patients how the antidepressants that they were prescribing work. However, it was quickly exaggerated till it was just a plain lie. Calling a mental illness a brain disease doesn't really improve people's attitude about it or any other mental illness, and this myth creates a barrier that prevents people from getting the best care for their problem. This is because the best outcomes are experienced by those who combine both medication and mental health therapy. And when people hear it's not a mental illness, they hear, I don't need therapy. The fact, as well as we know them, are that depression is a symptom of many other medical problems. Therefore, a good therapist will refer their clients suffering from mood disorders to a physician so that any biological causes for the illness can be ruled out. However, doctors routinely rule out any medical causes for the illness, and the implication is the cause is in the thinking and the social environment of the client. You may ask, well, isn't that how the medication works? By correcting an imbalance in the brain. The thing is that we're just not looking at a future where you can get a brain chemistry test and diagnose depression. The medication works very quickly and the imbalance is corrected in a matter of days, whereas it takes upwards of 2 weeks for most patients to see any improvement. Practically the only evidence we have that there ever was an imbalance is the fact that the medication works. And it really seems that that's pretty much just a coincidence now, and the medication works. Well, we're not exactly sure how the medication works. There's a video I've linked in the description that goes well into brain structures and brain chemistries if you want to understand this a lot better. At this point, saying that depression is defined by a chemical imbalance is a lot like saying that a broken arm is defined as a floppy arm and doesn't actually involve any broken bones, because a cast holding it straight is important in healing it. Depression is a mental illness that's hard on the brain and very likely does involve some chemistry changes, and also possibly even damage to structures such as the hippocampus. Therefore, treating the organ of the brain is an important aspect of the most effective interventions for depression. However, if your medical doctor diagnosed you with a mood disorder and then prescribed you antidepressants without referring you to mental health therapy, he or she has robbed you of the best chances for the best outcomes. This needs to stop. Medical doctors need to risk offending their obese clients, their clients who drink too much, their clients who smoke, to give them the best care. Medical doctors have no excuse to cower behind the stigma of mental illness. In this post-vaccination, post-antibiotic era, most medical issues are caused by the lifestyles and actions of clients. So, tell your depressed clients that the pills will help, but if they really want to get better, they need to take a full course of medical and mental health treatment. The next two myths we'll cover together. The first one is women are more likely to be depressed than men. That's number 2. Number 3 is women are more likely to attempt suicide than men. Now, these myths together kind of foster an attitude that depression is somehow normal for women, and it's normal for women to simply be on antidepressants, and it's just often not taken seriously enough as something that there's the expectation that they'll get better from it, and therefore they're just left on pills and not given the best care and the best support from the people around them. They don't get involved in their mental health treatment. On the other hand, the same myths mean that, support the attitude. They're not the only reason that we have this attitude, but they support the attitude that men are somehow immune to this disease, and we are just blind to the signs of depression in men. So, the truth is that more women are in treatment and or on antidepressant medication than men, while more men kill themselves. Well, it's commonly argued that women get this problem more often than men. The overall picture supports my belief that men are simply not getting help as often. What cannot be argued is the fact that this disease kills more men than women. So, if anything, men need to be more vigilant of the signs of depression than women do. When a man, as opposed to a woman, contemplates suicide, he is much less likely to consider help as an option. Why would he cry for help? He hasn't openly cried since he was truly a little child. So, men tend to use methods of attempting suicide that make survival very unlikely. Not only this, they usually put more effort into making sure they're not interrupted or even found. Because the same woman can have attempt after attempt, it simply means that women have a greater number of attempts of suicide. This doesn't tell us the likelihood for the people you know to make that first attempt based on whether or not they are a man or a woman. Myth number 4. People have mental illness or attempt suicide just for the attention. I think the barriers this attitude creates for people taking care of their own and being helpful to others' mental illnesses is pretty clear. If someone is willing to increase their chances of dying for attention, they need it. It may not be realistic to give it to them in the amounts and exact forms that they demand, but they definitely need help changing their lives so that they get more of their needs met. A phrase that is often used here that I just hate is attention-seeking behaviors. First, dismissing someone's suicidal demands or mental illness as demands for attention is a lot like not taking terrorism seriously simply because you refuse to negotiate with terrorists. I hate the term attention-seeking behavior because it sounds to me like the attitude behind it is these people are unworthy of attention. Everyone needs attention. Sick people get attention. There's at least 2 mental illnesses that revolve around this. But you don't cure obesity with starvation. Drug addictions are the best example, probably, of people with a mental illness that have a really hard time wanting to get better because there are some really strong advantages to not getting better. Change is hard for everyone, and almost all mental illnesses have their upsides, and that create barriers to people getting better. However, depression is misery. People might fake a broken leg to get out of work, but anyone who's actually tried breaking it knows that it's much better just to do the work. Payoffs don't cause mental illness, but they can be a crutch. And this, I think, gives us the right perspective. People with broken legs need crutches. But at some point, the person needs to give up the crutches and try walking on their own. Imagine if friends and family were the people who decided when the cast came off based on how annoyed they were that the person wasn't pulling their weight. More to the point, friends and family often attend medical appointments where doctors and nurses instruct them on how to help care for their loved ones. This is a good idea for serious mental illnesses, and it increases the prognosis. Number 5, there must be a reason. This is often a point of pain and perplexity to survivors. They want to know why they've suffered the tragedy that has befallen them, and they're left with unhelpful notes or nothing at all. I hope to offer some help here, as well as dispelling the notion that it's only people who have recently suffered some major tragedy that are at risk for depression and suicide. Life's little tragedies don't lead to suicide. Depression does, most often. Depression makes life not worth living. It takes the joy and the taste and smell of food. It makes hugs feel empty, and the loneliest place in the world is with a crowd of people. Most depressed people have gotten there through a long string of little heartbreaks, but they usually take time to fester and rob someone of every last reason to live. So while outsiders can look in and see lots of joys and reasons to go on, but for the individual, these are all hollow, lackluster, and hopeless. The point is that the best indicator of someone who is at risk for either depression and therefore suicide is someone who's suffered a long string of heartaches over time and someone who seems unhappy. Number 6. The problem is always psychological. Many people go into therapy expecting to be told that they have some kind of mood or anxiety disorder and instead are told something else. Their diagnosis reflects that they're somebody who is simply in a very bad situation, a situation that would make anyone mentally miserable. And the treatment is to simply support them through it and help them see the need, motivate them, and give them the tools they need to simply escape their sick environment. It's as if everyone with an ingrown toenail or in need of a few stitches thought that they were going to get open heart surgery. You can see how it would be a lot harder to get people treated for your minor sprains and medical problems if they thought major surgery was involved every time. In addition, people have the idea that treatment will be like a Civil War field hospital, intensive psychotherapy, where the therapist delves into the deepest, most sensitive areas of a person's psyche, are really only appropriate for dealing with intense childhood trauma or problems that are both severe and long-term. In addition, TV and movies, for the most part, are very antiquated and dramatic in their depictions of psychotherapy. So people get the idea that it's going to be a lot more uncomfortable and downright painful than it really is, particularly if your problem is relatively minor, like a simple phobia, or a relatively short-term recent development. Then relax. Therapy is likely to be quite comfortable, simple, and short.